Hello, my name is David Murray. I'm the Associate Director for Prevention and the Director of the Office of Disease Prevention at the National Institutes of Health. I'm pleased to welcome you to the second of three 2023 ODP Early Stage Investigator Lectures. We created this lecture to highlight early career prevention scientists who have not yet served as a principal investigator for a substantial NIH-supported research project, but who have made outstanding research contributions to their field and are poised to become future leaders in prevention research. Before we begin, I have two housekeeping items. First, you can submit questions during the webinar via the chat pod. You'll need to open the pod by hovering your cursor at the bottom of the Zoom window and then clicking on the chat icon. Please direct your questions to hosts and panelists. We will open the floor to questions at the end of the lecture. Second, let me note that the slides and video recording will be posted on our website in approximately 2 weeks. We're excited to present one of our 2023 awardees, Dr. Justin Echouffo. Dr. Echouffo is an associate professor at the Johns Hopkins University School of Medicine. His research focuses on the links between metabolic dysregulation and cardiovascular diseases. He has used various epidemiologic designs and investigational approaches, such as biomarkers and cardiac imaging, to explore the pathways leading to type 2 diabetes and to understand the pathogenesis and natural history of diabetes-related cardiovascular complications. Dr. Echouffo will use the example of heart failure today to illustrate the critical importance of cardiovascular disease prevention in the setting of type 2 diabetes. He will describe novel evidence on the links between type 2 diabetes and heart failure, and also elaborate on specific approaches to preventing heart failure in the setting of type 2 diabetes. Please join me in welcoming Dr. Echouffo.
Thank you, Dr. Murray. And I'm going to start by thanking the NIH for honoring me and giving me the opportunity to share some of the work that we've been doing on the links between type 2 diabetes and cardiovascular disease. And today my focus is going to be on heart failure. I'm going to start by mentioning the fact that most of my work is supported by the NIH. This is the outline of my talk, the different sort of concepts or ideas that I'm going to develop in this talk. In the interest of time, I'm not going to go through the details here. I'm going to start by pointing out the fact that historically, in the setting of diabetes, heart failure has been an under-recognized or underappreciated complication. And the reason I decided to focus on it is because I think that in terms of prevention opportunities, there are a lot of sort of opportunities that have not been explored in terms of heart failure related to diabetes. There are also major research opportunities because there are a lot of aspects of the link that have not been explored, at least in the epidemiological arena or realm. And there's also opportunity to explore novel therapeutics of heart failure related to diabetes. And the under-recognition was recently highlighted by the American Diabetes Association. As you can see on this slide, the American Diabetes Association published in July of 2022 a consensus report highlighting the importance of heart failure in the setting of diabetes. In the first part of the talk, I am going to focus on the burden of heart failure associated with diabetes. As I mentioned, sort of this burden is largely underappreciated or underrecognized. And until recently, there was not much data on that burden. This study that was published in 2015 in Lancet Diabetes Endocrinology is probably one of the most robust studies that highlights the importance of heart failure in the setting of diabetes. And the study was conducted within the English primary care. For those who have an idea of what the British health system is like, when sort of one leverages a primary care registry, such as what was done in this study, the Caliber study, it is highly likely that the data presented is going to be representative of the situation nationwide in England. And particularly in this study, there were more than 1 million individuals, close to 2 million individuals that were enrolled, and those individuals were aged 30 years and above, among whom more than 30,000 had diabetes. They were followed over a period of 5.5 years. And the investigator looked at the most common initial complication, cardiovascular complication in the setting of diabetes. Historically, the thought has been that coronary heart disease is the most common complication, cardiovascular complication in the setting of diabetes. But surprisingly, in this study, what the author found was that the most common initial complication in the setting of diabetes is peripheral arterial disease, followed by heart failure. Peripheral arterial disease represented 16% of cases, whereas heart failure represented approximately 14% of cases. And the manifestations of either coronary artery disease or stroke only came after. And this sort of highlighted the fundamental importance of heart failure in the setting of diabetes. One could say this is not by any means representative of what happens in the US. So what about the US? In 2016, we tried to address this question by using registry data, and the registry data that we used was from the American Heart Association Get With The Guideline Heart Failure Registry. And at the time, the registry included more than 300,000 heart failure patients admitted in 462 hospitals across the country. When we look at the frequency of diabetes among those admitted for the compensation of heart failure, we realized that 44% of individuals admitted to those hospitals for heart failure also had diabetes. And when we look at trends over time, which are shown on this slide from 2005 to 2015, the trends in the prevalence of diabetes were sort of increasing, and it didn't really matter what subtypes of heart failure one was dealing with. So the important point here is that if one looks at the different subtypes of heart failure, the frequency of diabetes was slightly higher among individuals who had a sort of more preserved ejection fraction type heart failure. You could see the prevalence was almost 47% among people with borderline ejection fraction heart failure, and it was close to 46% in those with preserved ejection fraction heart failure. Slightly higher prevalence of diabetes among people with a more preserved ejection fraction type heart failure. It's an important point because I'm going to come back to it later in the talk. One thing to say about these data is that obviously we were only covering at the time 462 hospitals. The situation may be different now in the registry, but this data is not sort of representative of the whole situation in the country. The other things to bear in mind is that the patients included in the studies were those hospitalized during the study period. There are many more people with heart failure out there in the community who were not necessarily hospitalized during that period. And the other aspect is that there's also a lot of undiagnosed cases of diabetes in the community, which may not be captured when one examines hospital-based data. What about data then at the national level? We do have some data at the national level. The data that we have originates from NHANES. A lot of you will be familiar with the NHANES survey. And in these studies, the investigator looked at the prevalence of obesity and diabetes among individuals who self-reported heart failure in NHANES between 1999 and 2018. And as you could see, as represented by the sort of the black bar on this graph, the prevalence of diabetes, depending on the cycle, oscillated between 31% and 49%, depending on the cycle. With the most recent cycle, a prevalence of diabetes among individuals who self-reported heart failure of about 45%. The numbers are sort of close to what we see in the hospital, but there's a caveat here. The caveat is that these are figures, or these numbers are most likely an underestimation of the burden of comorbidities or the co-occurrence of diabetes and heart failure, because a lot of the heart failure in these surveys is, as I mentioned, self-reported. It's not based on objective assessments of individual. That's sort of that has been the perennial problem in surveys of heart failure. And so there is a need for more robust national data, including a population that is really and truly representative of the US population. Now, having sort of elaborated a little bit on the burden of local co-occurrence of heart failure and diabetes, now I'm going to sort of elaborate a little bit on the extent to which sort of diabetes drives the heart failure risk. And I'm going to do this by showing, I'm going to start doing this by showing data from a systematic review and meta-analysis that was published in 2019. And the reason I choose to present data from this systematic review and meta-analysis is because I believe it's probably one of the most representative studies that we have there, because it pulled data from various cohort studies across the world. And the overall sample of the study was almost 12 million individual, or more than 12 million individual, and including a massive number of incident cases of heart failure. And the author looked at the relative risk of heart failure associated with diabetes, stratified by sex. They looked at women separately from men, because historically there's been a thought that, diabetes confers a slightly higher risk of heart failure among women compared to women. This is what was sort of observed in this study, where among women, the relative risk was sort of almost twofold higher in women with diabetes compared to women without diabetes, with a slightly lower relative risk among men, where the relative risk was sort of 1.7. Unfortunately, this study did not include absolute risk, because I think from sort of a prevention perspective, there is a need to understand not just the relative risk, but also absolute risk estimate. So because of that, I'm therefore showing you another study, or this study sort of included more than 3 million individuals in the Scottish primary care. And this is probably the largest study out there evaluating the absolute risk of heart failure associated with diabetes. And in these studies, patients from the primary care in Scotland were followed over a 10-year period. And the authors looked at the age-adjusted incidence of heart failure among men and women. And as you could see, the graphs are showing the age of the patient on the x-axis, and then on the y-axis, the incidence rate. And in men, the incidence of heart failure among people with diabetes, be it type 1 diabetes in green or type 2 diabetes, increase with an increasing age. And the incidence rates were higher among people with diabetes, irrespective of the type of diabetes. The same sort of pattern was observed in women. But I want to sort of highlight the fact that there was a higher absolute risk of heart failure in all the individual compared to younger individual, and a higher absolute incidence rate in men compared to women. But when the authors looked at the relative scale, in relative terms, the risk of heart failure was higher among younger individuals associated with diabetes, was higher among younger individuals compared to older individuals, and slightly higher in women compared to men, which is in conformity with the previous slide that I showed. And so one thing to highlight about this study is that although it's very informative, it may not totally or rigorously apply to the US, where the racial and ethnic composition of the population is different from that of Scotland. This study mainly included white individuals. And so there is a need for additional data that includes a sort of more multi-ethnic, multiracial sample, and to try and see if there's sort of racial and ethnic differences in the levels of risk. Now, having sort of had an idea of the extent of the risk, or the excess risk that is, excess risk of heart failure that is associated with diabetes, I think it's important to have an idea of the biological processes that drive the risk. And I'm showing here a schematic that was borrowed from a paper published in 2009, and this is mainly from sort of mechanistic studies and basic science studies, where the authors highlight the fact that in addition to hyperglycemia, there are many other physiological or pathophysiological processes that drive the risk of heart failure in the setting of diabetes. I think it is important to highlight that because generally, at least in the clinical community, the thought has always been that the key or the main thing in the setting of diabetes is elevated glucose. It is important to mention that there's also hyperlipidemia that drives the processes. And here I'm not just talking about hyperlipidemia at the periphery or circulating hyperlipidemia, because there's also a certain degree of hyperlipidemia in the tissues because there's uptake of lipids in the tissue, which leads to lipotoxicity and myocardial steatosis, which is not good for cardiac remodeling. Also good to bear in mind that the main substrate that is used in the heart is glucose, and there is a need for insulin, and also there's a need to have a certain degree of insulin sensitivity in the heart for the substrate to be used. Remember that as the skeletal muscle, the myocardium is also a muscle, so there is a certain degree of insulin sensitivity there. And so insulin resistance and insulin deficiency in the setting of diabetes also drive the process. I'm not going to go into the details of all the sort of the consequential processes or the processes resulting from the main processes that I mentioned earlier, but suffice it to say that the constellation of things that happen will lead to adverse cardiac remodeling, which in this case is called diabetic cardiomyopathy. It is important to understand that the metabolic processes or the biochemical processes that I mentioned in the previous slide ultimately lead to morphological and structural changes that are characteristic of the diabetic heart. And those structural and morphological changes are the processes that are responsible for the clinical phenotypes that we have. And on this slide, I'm highlighting three key structural and morphological changes. It is cardiac fibrosis, cardiac hypertrophy, which is probably a result of sort of a maladaptive process in the left ventricle, and also importantly, an impairment in the coronary microvasculature, which results in a decreased perfusion. Remember that diabetes is a microvascular disease par excellence, and even the way we define diabetes is based on a microvascular complication, which is retinopathy. Why is it important to understand these processes from an epidemiological perspective? It's important because, for example, when one thinks about the subtypes of heart failure, and in this case, heart failure with preserved ejection fraction and heart failure with reduced ejection fraction, there's been speculation in the literature, at least from sort of the mechanistic perspective, that the processes that lead to one subtypes of heart failure are different from the other subtype. Just for example, it's been speculated that, the main processes that lead to heart failure with preserved ejection fraction are sort of hyperinsulinemia and microvascular changes, including endothelial inflammation, which ultimately lead to ventricular hypertrophy and stiffness, hence the HFpEF phenotype. Whereas for HFrEF phenotype, there's a predominance of lipotoxicity and deposition of advanced glycation end product, leading to myocardial injury and ultimately cell death with a replacement fibrosis. So with this in mind, so one of the questions that we address from an epidemiological perspective is whether diabetes confers a differential risk of HFpEF versus HFrEF. And this question is important because for those who are familiar with the sort of clinical management of heart failure, HFpEF is poorly understood and it's sort of difficult to manage. And they are not, to my knowledge, they're not specific therapies for HFpEF as compared to HFrEF. And so we look at the risk of different subtypes of heart failure associated with diabetes using cohort data from the multi-ethnic study of arteriosclerosis, which is a multi-ethnic cohort. And in this investigation, we included more than 6,000 individuals who were followed over an average period of 15 years. On my right, you could see a Kaplan-Meier curve showing the sort of the survival free of heart failure across time in 3 groups. The green curve represents people with diabetes, the red curve represents people with pre-diabetes, and the blue curve represents people without diabetes. And obviously, the incidence of heart failure was much higher in this case, HFpEF was much higher in people with diabetes compared to people with pre-diabetes or without diabetes. A similar phenomenon was observed for HFrEF. But when we looked at the relative risk of each subtypes of heart failure in relation to diabetes, it was 1.9, almost 1.9-fold higher relative risk of HFpEF, whereas the relative risk of HFrEF was almost 2-fold. And the confidence intervals of the 2 estimates overlap. So we concluded that there's not much difference in terms of the extent of risk for each type of each subtypes of heart failure in relation to diabetes. And so now, having sort of elaborated on the extent of the risk, of the risk of heart failure conferred by diabetes, now, what I'm going to try and do in this section of the talk, it is to look at, the influence of diabetes across the natural history of heart failure. I think it's important to sort of bring into the picture the natural history of heart failure. If one wants to sort of have a complete understanding of the link between diabetes and heart failure, looking at things across the natural history, in my opinion, it's important, because diabetes is at play across all the stages of heart failure. In terms of the stages of the natural history of heart failure, I think up till now, there have been 2 classifications or 2 attempts to sort of give us an idea of the various stages. And the first attempt was in 2013 by an American Heart Association and American College of Cardiology, where they described the stages that are shown on this slide. And with a stage 0 being a stage whereby individuals don't have risk factors for heart failure. In stage A, individuals have 1 or more risk factors, but without any sort of structural myocardial change. In stage B, they have a certain degree of structural or functional myocardial change, but those changes are sort of asymptomatic. And in stage C, they have symptoms of heart failure. And this stage C is the ones that we usually see in clinic. I have to point out that more recently in 2021, there was an enrichment of the definition of stage B in the universal definition of heart failure, where, in addition to the structural changes, it was suggested that the levels of biomarkers, namely high sensitivity troponin and NT-proBNP, could be used to enrich the definition of stage B. My contention is that the impact of diabetes or the effect of diabetes, is at play across these stages. And so I'm going to illustrate it in the following slide. One key reason to sort of have an idea of the natural history is because certain stages of the natural history of diabetes may offer a better opportunity for prevention, especially secondary prevention. And just to illustrate this, for example, stage B, one of the things that we sort of realize is probably in the community more prevalent than the heart failure, the overt clinical heart failure itself. And we looked at this question a couple of years ago in this meta-analysis, where we pulled data from various cohort studies conducted mainly in the US. And then we looked at the prevalence of asymptomatic left ventricular systolic dysfunction, which was only defined using ejection fraction at the time. And the sort of overall prevalence in our data in the community was 4.7%, which is already much higher than the prevalence of heart failure itself. One thing to point out is that this is probably an underestimation of the prevalence of stage B of the heart failure process, because our definition of the structural functional defect was only based on ejection fraction. So, and the underestimation is illustrated by data from a study that was published later in Circulation by sort of Emil Shah, where he leveraged data from the atherosclerosis risk investigation in community cohort, which is a well-known NIH-funded cohort study. And he leveraged sort of echocardiographic data to better sort of define the symptomatic left ventricular dysfunction. So he used indices not just of ejection fraction, but also indices of, other aspect of functionality of the left ventricle, and also the valves. He came up with the conclusion that in this particular cohort in the community, the prevalence of, stage B heart failure was quite high. It was 30%. So this is an important segment of the population that sort of needs some sort of addressing. And we sort of surmise that, or we anticipate, or we project that the prevalence of stage B heart failure will even be much higher if one were sort of to include the biomarkers in the definition. And this is what we did. We leveraged sort of the work done by Emil Shah and then enrich the definition of stages using the biomarkers and to sort of characterize the impact of diabetes on the progression of cardiac dysfunction. And this was done in this investigation that was published in 2022, where among more than 4,000 individuals, we've conducted follow-up over an average period of 7.5 years for the incidence of heart failure in different subgroups. And the subgroups were defined based on the stage of heart failure and then on the diabetes status. We had four groups, a group that had stage B sort of heart failure and diabetes, the red group on this Kaplan-Meier curve. The second group were people in stage B but without diabetes. And the third group were people in stage A of the heart failure process with diabetes. And the last group were people in stage A without diabetes. And that last group represented sort of the reference for our comparisons. And as you could see, when we sort of look at the incidence rate of heart failure over time on these slides, heart failure was much more common in people in stage B and diabetes compared to the counterpart in stage B but without diabetes, and sort of much, much higher than anybody in stage A, so much so that heart failure developed in people in stage B and diabetes 3 years earlier than in their counterpart in stage B without diabetes, and 5 to 6 years earlier than individuals in stage B. And in relative terms, when they were compared to our reference, the individuals in stage B and with diabetes had a almost 3.4-fold high relative risk of heart failure. And our results in this particular investigation suggest that, in the early stages of heart failure, diabetes is probably an accelerator of the cardiac remodeling and cardiac dysfunction. And so one key question in this investigation that we address is, what is the impact of the external glycemic control on this progression? Because remember, in the previous slide, what I showed you was only based on diabetes status itself. It didn't sort of factor in the degree of blood glucose control. And we did this by looking at the relationship between A1C and the incidence of heart failure in stage A, including both people with diabetes and without diabetes, as shown on this figure, which is a spline. And then we also did it in stage B. And as you could see, when we look at the curve, describing the relationship between A1C and the incidence rate of heart failure, there's a much stronger and a steeper relationship between, A1C and the incidence of heart failure in people in stage B. This suggests that when people are in stage B, there's a more potent effect of diabetes on the acceleration of the sort of heart failure process, if I may say so. So glycemic control is sort of an important, aspect to account for when trying to prevent diabetes. Now, in the previous slides, as you sort of realize, what I did was to focus on the sort of early stages of the heart failure process, stage A, stage B. But what about the much later stage of the heart failure, process? And so we sort of try and address that question by looking at people with already established heart failure who were sort of supposed to undergo cardiac resynchronization therapy. And we did this by using data from the National Cardiovascular Disease Registry. And in this investigation, there were more than 18,000 people who were followed over a 3-year period. Just as a reminder, cardiac resynchronization therapy is generally done in people with advanced heart failure with reduced ejection fraction, mainly people with an ejection fraction that is 35 or less and who have a left bundle branch block. And the hope is that the resynchronization is going to improve the outcome and possibly stop the remodeling of the heart. And then our contention in this investigation was that diabetes was sort of going to adversely affect those sort of beneficial effects. And we looked at mortality, and we also looked at readmission. Both for mortality and readmission, as you could see on these curves, the incidence rate of mortality was much higher over the 3-year period in individuals with diabetes, sort of represented here in blue, compared to individuals without diabetes. The same phenomenon was observed with readmission, all-cause readmission, and also readmission due to cardiovascular reasons. It didn't really matter, what was the reason for the readmission. So individuals with diabetes, represented in blue, were more likely to be readmitted in the hospital than those without diabetes. And so when we look at the relative risk, they were pretty similar for both mortality and sort of readmission when we compare people with diabetes to those without diabetes. So bottom line, the result of this study suggests that even at advanced stages of the heart failure process, diabetes has sort of a bad effect on the outcomes. And so the next series of aspect that I'm going to be elaborating on in this part of the talk, I'm going to talk a little bit about some of the drivers of the heart failure risk that may be very specific to diabetes. And I'm going to start by, highlighting insulin resistance. Remember, when I was mentioning the biological and the pining, I sort of insisted on the fact that, insulin resistance plays a role. Quite often in the setting of diabetes, we tend to think only about, glucose, or we're much more interested in lowering glucose, but the process that leads to diabetes is a lengthy one, and insulin resistance plays a role. And even when people are treated for diabetes, generally we do not address insulin resistance, which is in the background and it's still sort of causing adverse effect. And so we looked at insulin resistance and the incidence of heart failure in this meta-analysis of various studies, cohort studies, mainly from the US and also from Europe. And the studies mainly included people without diabetes. Some of the people included certainly have diabetes, and also people with newly diagnosed diabetes, mainly from the United Kingdom prospective diabetes study. And so when we compare the top tertile of the distribution of HOMA-IR is an index of insulin resistance, to the bottom tertile of its distribution, realize that those in the upper tertile had a 15% higher relative risk of having heart failure compared to those with a lesser degree of insulin resistance, suggesting that insulin resistance is an important sort of driver. And this is, I have to point out, this is accounting for the degree of blood glucose level and all the other factors. Just to sort of, strengthen the point about insulin resistance, I'm showing data from a study that was conducted much later in the sort of natural history of heart failure. And this is among people with established heart failure, chronic heart failure. And in this study, Stephen Anker and collaborators showed that among people with already established heart failure, when patients were classified according to their functional capacity, defined here by the New York Heart Association stages of heart failure, 1, 2, 3, 4. Those with sort of a lesser degree of functionality had a high degree of insulin resistance, shown here in this sort of graph by a lower level of insulin sensitivity. Insulin sensitivity is the converse or the opposite of insulin resistance. And the degree of insulin sensitivity among people with chronic heart failure had an impact on outcome, both on survival and then also on the exercise capacity as evaluated by VO2 max. And this survival curve shows that there was a better survival in people with a high degree of insulin sensitivity compared to people with a lower degree of insulin sensitivity. And this is sort of very well illustrated by the hazard ratio shown here. And this is just to say that even at sort of advanced stages of heart failure, insulin resistance is still sort of an important driver of the process. Now, I'm going to sort of briefly talk now about, the impact of the duration of diabetes, the duration of disease on the risk of heart failure. And to address this question, we leverage data from the ARIC cohort. And in this investigation, we included more than 9,000 individuals who were followed over a period of 22 years on average. And then we looked at the relationship between the duration of diabetes and the risk of sort of heart failure, as shown on the graph on my right, which is a spline, which shows the duration of diabetes on the x-axis and then the risk on the y-axis. As the duration of diabetes sort of increase, the risk of heart failure also increase. So the question now in this context is this driven by the degree of blood glucose control? So we may just be in sort of calculating the duration of the disease, be capturing only individuals who have had a poor blood glucose control over time. To disentangle the question, we stratify our sample by the level of blood glucose control, and the individuals with controlled diabetes were those who over this observation period permanently had an A1C below 7, compared to the rest of individuals with uncontrolled diabetes, those individuals who at any point in time had an A1C that was greater than 7. As you will see here, there is also a significant increased risk of heart failure associated with the duration of disease, even in people with controlled diabetes in blue. And that risk is sort of much higher, much more significant in people with uncontrolled diabetes. So our sort of study overall confirms that the duration of disease, it's an important factor, regardless of the degree of blood glucose control. And just to indicate that the concept that the duration of disease is capturing it's a way of sort of capturing all the sort of processes that are going on in the setting of diabetes. Another specific driver that we looked at was the presence of microvascular disease. Remember, I mentioned the fact that, there is a microvascular impairment in diabetes, and we sort of hypothesized that the presence of the microvascular impairment will sort of drive the risk of heart failure. We did this by using data from more than 4,000 individuals with diabetes from a multi-ethnic cohort who were followed over an average period of 9.7 years. And we separated our sample into two groups, those with any microvascular disease in red on this graph. And the microvascular disease here was either retinopathy, nephropathy, or peripheral neuropathy, and those without any microvascular disease. As you will see over time, the cumulative incidence of heart failure was much higher in people with any sort of microvascular disease compared to those without any microvascular disease. And this is also very well reflected in the relative risk, which was 2.44 higher, relative risk of heart failure, 2.44 higher in people with any sort of microvascular disease compared to those without any microvascular disease. But what I would like to point out is that in this study, we use peripheral neuropathy as a proxy of what could potentially be happening in the heart. We believe that, looking at neuropathy in the myocardium is probably much more reflective of what impacts cardiac remodeling and ultimately the risk of heart failure. And sort of we investigated the question of the association between cardiac autonomic neuropathy and heart failure among people with diabetes, using data from more than 7,000 individuals who were followed up over a period of an average 5 years. And we defined the presence of autonomic neuropathy using data from the EKGs that were done at baseline. Remember that one could sort of have an idea of the balance between the parasympathetic and the sympathetic nervous system by looking at heart rate variability and using the index of heart rate variability to define who has cardiac autonomic neuropathy or not. And so when we compare individuals with cardiac autonomic neuropathy to those who are sort of illustrated here in red on this curve, to those without cardiac autonomic neuropathy, the incidence of heart failure was much, much higher in people with cardiac autonomic neuropathy compared to those without cardiac autonomic neuropathy. And this difference in incidence rate of heart failure is also well illustrated by our estimate of relative risk, which is the hazard ratio that is significant here, suggesting that cardiac autonomic neuropathy plays a role. It drives sort of the heart failure process in the setting of type 2 diabetes. So now, having sort of elaborated on the burden of comorbidities or co-occurrence between diabetes and heart failure, elaborated on the extent of the risk and the sort of the drivers of the risk, one of the key questions that needs to be addressed is how do we sort of identify people who have diabetes-related heart failure? Are there sort of specific markers that could help the identification? Bear in mind that, you know, there are traditional ways of sort of detecting heart failure early, which is based on the traditional biomarkers and imaging. But the question that we sort of pose ourselves is, are there specific markers that may be more informative in the setting of heart failure, both for our sort of fundamental understanding of the pathophysiological links, but also for possible clinical use for detection and management. And in this slide, what I'm basically trying to illustrate is just to say that a lot of the mechanisms or the pathways linking diabetes to heart failure that we know stems from animal studies, preclinical models. And we believe that, you know, measurements of a large number of proteins using proteomic techniques could sort of help us to have a better understanding of these links in humans and then ultimately find biomarkers that are specific to diabetes-related heart failure. And so we did that by sort of leveraging data from ARIC once again, in leveraging a cohort of more than 10,000 individuals, among whom almost 15% had diabetes. And all those individuals had sort of the circulating proteins in the plasma measure using the SomaScan platform, which is one of the sort of base platform existing out there in terms of proteomics. And then those individuals were followed over a period of at least 24 years or 24 years on average. And then to be able to sort of conduct our analysis, we had sort of a discovery phase, which used 2/3 of the sample, and then a validation phase, which used the remainder 1/3 of the sample. When we did that, we identified a number of proteins that were specifically associated with heart failure in the setting of diabetes, 19 in the discovery phase, and these are shown on this volcano plot, some of the top protein and easily recognizable. Here you have NT-proBNP, NPPB, and this is the CLIP2, which is generally found in a lot of the proteomic study, and then some of the proteins are sort of quite novel, including semaphorin 4D and semaphorin 6A. When we did the validation, in the remaining 1/3 of the sample, 12 of the 19 protein sort of were significantly associated with heart failure in the setting of diabetes. And there was this consistency in the magnitude of the association with heart failure and the direction of the association with heart failure. So just to sort of give you more detail, I listed all the proteins that we sort of identified, the 12 that validated. And some of those proteins are shown in the third column on this table are also strongly associated with prevalent diabetes. And just to highlight a few of them, which possibly may uniquely sort of be identified or may uniquely be related to heart failure in the setting of diabetes, are the semaphorins. They were not sort of novel, they haven't been described before. And so the hope is that understanding more about these proteins will help us to understand the pathways linking diabetes to heart failure, but ultimately may serve as sort of targeted assay that we could use for early detection. So just to sort of close the talk, I'm sort of going to briefly elaborate on some aspects of the prevention of heart failure, since this talk is mainly about prevention. All the previous slides that I showed were basically just to give ourselves an idea of the different aspect or the different influences that ultimately leads to heart failure in the setting of diabetes to inform prevention and ultimately therapeutics. What about prevention? Are there preventative efforts going on now in the community or in the clinic, for heart failure in the setting of diabetes? I'm going to sort of just show this approach that was suggested in the 2022 ADA consensus report, whereby the author recommended sort of systematic screening for heart failure among people with diabetes, especially people who are in stage A and stage B. What they're recommending is to test the biomarkers on a regular basis every year. And if they're elevated, people should proceed to imaging. And this is mostly echocardiography, and then ultimately have a diagnosis of heart failure. This is a proposition. It's unclear to what extent this is being implemented. It's just very recent. But there are also some challenges in sort of implementing prevention of heart failure in general and prevention of heart failure in the setting of diabetes. We do not have sort of robust data from a trial of screening, so we don't know whether the strategy that was proposed is going to be effective in preventing outcome or not. One of the key aspects is that we also lack trial data on strategies or therapies that can be used in early stages of heart failure, especially stage B. There are candidates, drugs that are listed here. In the interest of time, I'm not going to elaborate on them, but they've not been formally proven to improve outcome when administered in stage B of the heart failure process. And obviously, there is a lack of data on cost and effectiveness, cost effectiveness. So we need those data because, if we're going to be increasing the number of people that we need to take care of within the health system, we need to know how much it's going to cost because we may need to strengthen the healthcare system. So I'm just going to end here by saying thank you to the NIH and thank you for all of you who are on the platform to listen to the talk. And I'm going to take a few questions. So.
Thank you very much for your presentation. We have a number of questions, so let's get started on that. Lifestyle modification, including exercise and diet, have been shown to reduce risk for diabetes in a number of clinical trials. What's the place or the role of lifestyle modification in the prevention of diabetes-related heart failure?
Thank you. That's an excellent question. I think we don't have direct data, but as you mentioned, we can use indirect evidence from the field of diabetes, also from the field of heart failure, because we know that, for example, physical activity is the determinant of diabetes. We know that physical activity is a determinant of heart failure. So it's only logical to think that if we were to increase physical activity, we will prevent both diabetes and heart failure, considering the fact that they are similar risk factors, they share risk factors. And so, and the other thing is that, if you prevent diabetes, you ultimately sort of, in this particular case, prevent heart failure. So if one were to think about a strategy, lifestyle modification will play a key role. And so the question will be, where do we sort of implement the lifestyle modification strategies? Is it in the clinic or is it in the community? The same thing is true for nutrition. So the same diets that are been shown to sort of have a preventative effect on diabetes also have a sort of positive effect on preventing heart failure and also, preventing adverse outcomes in people with heart failure.
You presented some data from clinical trials, but it was often survival analyses comparing groups at different levels of risk or who had different characteristics, as opposed to survival curves based on treatment arms in those clinical trials. Can we use the data from the clinical trials that have been used to evaluate the effect of lifestyle modification and drug therapy on diabetes to evaluate their impact on heart failure? Or
In
is it a sample size problem?
In theory, one could, because if the heart failure outcomes was sort of obtained in those clinical trials, one could theoretically do that. But as you sort of rightly pointed out, one issue is that none of the trials was powered on the heart failure outcome. So and as you may know, a lot of the trials are sort of powered on a composite outcome. And then when you sort of drill down and go to individual sort of cardiovascular outcomes, it becomes difficult to really show a difference. And so maybe in the future, we should not just focus, we tend to do that, we tend to focus on composite outcomes, but sometimes looking at individual outcomes may be informative. And so maybe, the future clinical trials shows, should also make sure that they have power to look at secondary outcomes.
Yeah, the power is always a challenge. You need bigger studies, and bigger studies cost more money, so that's a problem. Mm-hmm. But epidemiologists are used to looking at the data and judging whether there looks like there's a trend that might suggest benefit from an intervention, even if the p-value is not very interesting. Have you or others done that in terms of heart failure as an outcome in any of these clinical trial data?
Not specifically. Well, I mean, remember the two trials data that I sort of showed was from the ACCORD study. ACCORD is a little bit difficult to leverage given all the sort of problems that we observe with the intensity of the intervention. And then there was also the look ahead data, which overall was sort of a negative trial. So I think had it not been for those two things, I believe there is a possibility, if the trial doesn't present those limitations, to sort of leverage that data, because as you mentioned, doing a new trial is sort of costly and challenging.
Yeah, as you and I were chatting before your presentation, the U.S. Preventive Services Task Force is probably the group that would make recommendations related to prevention, or at least preventive services regarding heart failure. And they make recommendations relative to screening, to preventive chemo prevention, and also behavioral counseling. So those are the three categories of things that they make recommendations on. So lifestyle modification would probably fall into the behavioral counseling, the drug therapies obviously into the preventive medications. And you've had an earlier slide about screening, so that's another thing that falls in their purview. They haven't made any recommendations related to preventive services for heart failure, and that is because they don't have sufficient data on the benefits and harms of screening, for example, or of therapies, or of other preventive services that might be offered. What kinds of studies should NIH support in order to provide the kind of data the task force might need to issue an A or a B recommendation in the area of heart failure, whether it's in the context of diabetes or otherwise? You've got NIH's attention right now. So what kind of research should we give you money to do?
That's a very difficult question, and there are several aspects to the difficulty. So ideally, and as you sort of mentioned earlier, in order to make recommendation, the best sort of type of evidence would come from clinical trials. And in the setting of screening, it would be a clinical trial where one compares screening to no screening in order to avoid some of the biases, and especially the lead time biases and the length time biases that one could observe if one were to use observational data. However, it may be difficult to sort of conduct those screening trials. And to my knowledge, historically, it's been sort of very difficult, even for things like cancer. We've done, cervical cancer screening without really any trial evidence. In the beginning, when we sort of instituted the cervical cancer screening, there was no trial evidence. The trial evidence came much more later. I also have a little bit of experience with diabetes screening. There was a trial that was conducted between 3 countries, the UK, Denmark, and the Netherlands. And ultimately, the trial was a null trial because the standard of care sort of evolved over time in the study. And then it was really difficult to sort of detect a difference between the 2 groups because the practices changed and people were screened anyway. So there is a certain degree of, already ongoing screening in the community. So expecting to have evidence from the best conducted clinical trial with, in sort of the best scenario, may be sometimes unrealistic. Maybe sort of other designs may help, address the issue. And historically, for cervical cancer screening, people, use much more observational type data. The screening was conducted, and there was sort of there were time series analysis that were conducted to see, to compare periods over which different sort of recommendation or different practices were sort of conducted to be able to have the evidence. And the same thing with diabetes. We recommend screening for diabetes, but we don't have data from a clinical trial. Talking about heart failure specifically, I don't think it's going to be different from other, conditions. There is no formal recommendation, as you said, from the Preventive Task Force, but I don't think we should be waiting to have the best, the clinical trial evidence. We should sort of use indirect evidence. But I think the critical thing that we should have, if we go by the Wilson and Younger criteria, we should make sure that we have therapies that we could use if we detect people. And this is particularly important in heart failure, because if you're detecting people early in the process, there are people with stage B. As I mentioned in the talk, we have to make sure that we have appropriate intervention. Obviously, lifestyle modification will be an appropriate intervention, but what about the drug intervention? So do we have sort of interventions that lead to a significant improvement in outcome? Because otherwise, it's going to be, an exercise that's not going to yield benefits.
Right, and that's actually something that the task force pays attention to. There has to be some step that you can take once you've identified positives using a screening procedure. If there's no effective therapy, they're not going to endorse the screening. So that's important. One of the problems that the task force often has in developing recommendations is that the data available are not representative of the U.S. population. The data come from largely white participants, often more men than women. You showed us some data that was included different racial and ethnic groups. In general, what's the state of the data in heart failure and diabetes with regard to diversity?
With regard to diversity, we touch a little bit on the male or the men and women subgroups. So there is generally the belief, which is somehow sort of corroborated by the data, that women will overall have a higher relative risk of having heart failure in the setting of diabetes. They probably, especially younger women, lose their sort of premenopausal protection that's in the setting of diabetes. It's been sort of shown in various cohort studies. Now, the racial and ethnic diversity is a little bit more difficult to sort of, it's difficult to know exactly what is the situation because, as I said, we don't have very good sort of national data. But overall, when one looks at individual cohorts, especially cohorts that have sort of included, multi-ethnic, samples, there is always, at least in relative, in absolute terms, there's a higher incidence of a higher rate of events in people from ethnic minorities, especially when you compare, for example, Black and whites. You're going to have a high rates of events in people who are Black compared to people who are white. The reasons are sort of somehow straightforward. You know, they have more diabetes in people who are Black. You know, even when you look at the national data in the US, the prevalence of diabetes is higher in sort of those groups than in white. So it's highly likely that the rates of events are going to be higher if one were to sort of look at the national data in people who are non-whites. So that's my projection.
All right. We have reached the end of our hour, so I want to thank you very much, Dr. Echouffo, for a terrific presentation and very interesting discussion. I want to thank our attendees for good questions. As I mentioned earlier, we will be posting the slides and a recording of today's presentation on our website in the next few weeks. Usually takes about a week or 10 days. Thanks everyone for joining today's lecture, and please join us on June 7 for our final early stage investigator lecture. Thank you very much.